Hi, David Rosenberg here for the Psychopharmacology Institute. In this CAP, or Child and Adolescent Psychiatry Smart Take, we'll take a close look at early emerging and late emerging side effects of antidepressants in youth and key strategies in assessing, monitoring, and managing these side effects. This is so important as antidepressants, particularly the selective serotonin reuptake inhibitors, or SSRIs, and the serotonin norepinephrine reuptake inhibitors, SNRIs, are first-line pharmacotherapies for the most common neuropsychiatric disorders, especially depressive and anxiety disorders. We still don't have a good handle on antidepressant-associated side effects and how to best identify, monitor, and manage them. The same goes for discontinuation of antidepressants in children and adolescents, since most studies to date haven't even reported whether or not these medications were discontinued right away or tapered. Frankly, most clinical trials haven't reported on taper or discontinuation side effects or rebound phenomena at all. Strawn and colleagues therefore provide a thoughtful and comprehensive examination of the most common antidepressant-related side effects in children and adolescents. In addition, they do a deep dive examination from the largest SSRI trial in pediatric patients with anxiety disorder, or the CAMS trial of children and adolescents with anxiety 7 to 17 years of age, randomized to sertraline CBT, sertraline only, placebo only, or CBT only, and they provide guidance on how to manage side effects and strategies for discontinuing antidepressants. So what did they find? SSRIs and SNRIs are associated with both early emerging side effects, which are most commonly transient, that is, they go away, and late emerging side effects in children and adolescents treated with these medicines. Unfortunately, clinical trials of antidepressants in youth to date typically don't report on the time course of side effects and adverse events, more just saying if a side effect or adverse event occurred. That being said, most of us are aware that there are some side effects that are present early, such as activation, GI symptoms, and sedation, and they tend to resolve quickly. So it's important to be proactive here and discuss with patients and their parents which side effects are likely to be transient, which are likely to persist, and which can occur later in treatment, such as weight gain. Another critical point is that sometimes it can be very challenging to disentangle side effects from an antidepressant and the signs and symptoms of depressive or anxiety disorder. So it's critical to get baseline functioning, signs and symptoms before starting the medicine. For example, sleep disturbance can be seen with antidepressants, but are also hallmark symptoms of depression and anxiety independent of medication. So again, assessing for this before starting treatment gives you a baseline and can facilitate treatment and delineation for what is and isn't a side effect. An exciting area of discovery and new work has found that many early emerging side effects such as activation, as well as late emerging side effects such as weight gain, are related to unique and individualized pharmacokinetic factors that are linked to cytochrome activity. Now, this is still a work in progress, but stay tuned as this is a hot area of research with exciting new findings that may guide clinicians in the trenches in the future. Early emerging side effects such as GI symptoms from antidepressants can be influenced by the underlying depression and or anxiety and their severity. The good news is that GI symptoms typically improve with treatment, either antidepressant treatment, psychotherapy, or their combination. Insomnia is another commonly reported side effect reported in clinical trials of antidepressants in youth with depression and anxiety. As we've said, the problem is that unfortunately baseline rates of insomnia are not consistently reported in the clinical trials. Insomnia and sleep disturbances are clearly associated with depression and anxiety, independent of antidepressant treatment. The good news here, too, is that insomnia is often transient. And for those children and adolescents where persistent insomnia, behavioral sleep hygiene, healthy sleep practices not drinking caffeine, colas later in the day, that kind of thing can be helpful. Fatigue, low energy, tiredness, and sedation can overlap with depressive and anxiety disorder signs and symptoms. It looks like fluoxetine and fluvoxamine are associated with more side effects compared to placebo. In my own experience, I find that to be the case with paroxetine as well. Activation in SSRI-treated youth is manifested by increased activity, irritability, disinhibition, and restlessness. And this can concern a lot of people, particularly since we know that antidepressants can be associated or trigger mania, hypomania. But activation typically presents early in treatment or shortly after an antidepressant dose increase. Managing activation includes proactive education of the child and parents with reassurance that most often this is transient as the child becomes tolerant to the medicine. Still make sure the parents and adolescents know to call and let you know if this occurs. Typically, it's best to either reduce the dose and use a more gradual upward dose escalation approach. And in youth who experience activation at higher doses of SSRIs, decreasing the total daily dose or stopping the medication reduces activation. Hyperhidrosis or increased sweating is a persistent or late presenting side effect seen with antidepressant use. This risk appears to be related to affinity of the antidepressant for the dopamine receptor, so it may be more common in second-generation antidepressants. When hyperhidrosis does occur, it's typically managed with low-dose glycopyrrolate, which is available in oral formulations and an orally dissolvable tablet. One advantage of glycopyrrolate is that in contrast to other anticholinergic agents, glycopyrrolate is limited in its ability to cross the blood-brain barrier, so this can minimize CNS side effects. Topical agents such as glycopyrronium tosylate has also been used in children and adolescents with hyperhidrosis, and it's actually FDA approved for primary axillary hyperhidrosis in persons 9 and older. As we all know, headaches are commonly reported in antidepressants-treated youth, but they're also more commonly seen in depressive and anxiety disorders. And it's worth noting that tricyclic antidepressants and 5-HT1B, 1D agonists have actually been used to treat headaches and for prophylaxis against getting a headache. Antidepressant withdrawal syndrome in youth is, again, not well described. A fruitful area of inquiry is to examine pharmacokinetic risk factors for discontinuation and withdrawal. Although more study is clearly needed, it's been suggested that relapse risk may be highest in the first 3 months after discontinuing SSRIs, even long half-life SSRIs like fluoxetine. Side effects, withdrawal effects in youth are also influenced by developmental pharmacology. Unfortunately, while side effects are listed in published clinical trials, their temporal stability or lack thereof has not been adequately addressed or reported. So going forward, clinical trials incorporating pharmacokinetic measures and proactively assessing for early, late, and persistent medication side effects is critical to properly delineate a side effect stability or lack thereof, impact of discontinuation, and tapering of the medication.